Hello and welcome to This Is Your Brain on Drugs Psychiatry podcast. This is the punk rock psychiatrist, Dr. Cody Armstrong here. And we've got another episode on the depression series. And I'm just trying to get my screen sharing up, though it's not working very well. Last time it worked for a third of the video, which is better than it has been, but I'm still struggling with that, so please be patient and hopefully you can download the content and listen there if that is what you're looking to do. So today we are going to talk about the monoamine oxidase inhibitors. I think these are medications that they used to be used because they were pretty much the only things around, and I haven't been around long enough to have been one of those people that frequently prescribe them to patients. I did go to medical school a little bit later in life, and I'm still in my 40s. So I've actually only prescribed one of these one time. So I want to be upfront, with the things I do have like experience with and the things I don't. But I have done a significant amount of research to get the details for you so that you can understand what these are, when to use them, etc. And the more I learned about the MAOIs, the more I feel like I wish I had used them more. And I think when you're dealing with a military population, these medications, especially when you're stationed overseas, they're not available in the pharmacy. These are not commonly given medications, and so in many respects, for much of my time, I couldn't even order them. It wasn't even an option. And then when you're treating, a military population, if you're so sick that we've gone, you're so, depressed and suicidal and really not doing well, that, we've worked our way up to needing to give you an MAOI, you probably are not suitable to stay in the military. So a lot of the folks, they just, and then you're out of the military by one way or the other. So that's a big reason, not having access to it for 6 years of my career, just with the pharmacy, and just not having a population where these would be indicated. But the more I learn about them, I think that there are some patients I think I wish I had given these to. And there are people that I was getting them out of the military, but they weren't quite out yet. And I wish I had known more about these. And so I hope that you're going to know more about them, and maybe you're going to feel more comfortable, because these can be scary. And I think most of you know why. And part of the point of the podcast is I want to put all that out on the table so that you know exactly what you need to be scared of and how to prevent it, so that you feel safe giving these medications to folks. So let's first, I just want to go through a list of the medications and kind of a history. So the first group we're going to talk about are non-selective irreversible. All right. And so this is actually an aspect of these medications that doesn't apply to any other psychiatric medications. There are some non-selective medications. So there are two. You have MOI, sorry, MAOA and a B. So you've got the monoamine oxidase, a type A, and you've got type B. And so the non-selective inhibitors, they affect both A and B. And then there's some selective ones that I'll talk about next that selectively block A or B. Okay, so you've got two you've got two of these MAOs in your body. And so these are the non-selective ones. And then they're also irreversible. So this is something that there are other medications that are irreversible, but as far as psychiatric medications are concerned, I'm not sure if I can think of any. So irreversible means essentially the way these medications work is they go in and they disable this enzyme. They disable it, and then they float out of your system. So you take this medication, it goes in, it disables the enzyme, the MAO, and you metabolize the drug out of your system, but the MAO is still in a state where it doesn't function. And it has a life cycle of 2 weeks. And so that's why, I think if you ever read this, or if you're ever looking at things and you're like, don't take within 2 weeks of an MAOI. And the reason for that is not that these drugs last 2 weeks, it's that the effect that they have lasts 2 weeks. So this is actually something that's going on in the mitochondria of your cells, and it takes 2 weeks before your cell turns that enzyme over, excretes it and produces a new one. And so that's why we have to wait 2 weeks if there's a drug interaction that we're concerned about. And there are some reversible. So that's why I said these are irreversible, means they irreversibly inhibit that MAO, and it can't be undone. It changes its shape, it locks it into place. It's in your brain, but it's not doing anything. It's not breaking down these serotonin, norepinephrine, dopamine, etc. And so there is a reversible, and we'll talk about that in a second as well. So these are the non-selective, meaning that they hit A and B, and irreversible, meaning that they permanently disable the MAO. And the very first one was iproniazid. And I'm not sure if I'm pronouncing that right. Is it iproniazid, ipronizid? It's really not that important because it has not been available to use for a very, very long time. This is a medication, and this is what you're going to see when you look at the history of all these psychiatric medications, is they were initially looking for something else. Often it was an antihistamine. And in this case, it was a medication against tuberculosis. Tuberculosis was and still is a very horrible disease, but a lot more people used to get it. And so there was a lot of searching to try and find medications that helped with this. And iproniazid was one of the medications that they had developed for tuberculosis. And in 1952, they discovered that it had this antidepressant effect. They gave it to people and noticed, hey, the depressed people aren't as depressed, and maybe it's this medication. So it was actually the very first monoamine related antidepressant. And I mean, we could, the very first modern antidepressant that, as we talked about in the last lecture, was not a barbiturate or a benzodiazepine or an opiate or an amphetamine. This was the first, what it actually did was depression, right? However, it was withdrawn from the market in most of the world in the 1960s because it was causing hepatitis, inflammation of the liver. And so it came and went, but there were several other drugs that followed it. And the next three I'm going to mention are the ones that are still available today. So isocarboxazid, name brand Marplan, came out in 1959. Phenelzine or Nardil from 1961. And then trancypramine or Parnate in 1961. And so you can still prescribe those three. And they've been around for over 50 years now. Over 60 years now. And so remember I mentioned the MAOA and B. So and that those were non-selective. Let's look at the selective ones. So what medications affect only A? So moclobemide. So this is a medication that's actually reversible. So this is, when I mentioned that those were irreversible and you had to wait the 2 weeks, this one's reversible. It's in some countries, and if you're listening from other countries, I'm ecstatic, because if people outside the United States are finding the podcast too, that's amazing. But I think Canada and a number of other countries actually have this medication. It's not FDA approved in the United States. You can't get it in the United States. And from what I've read, there's no real reason to. It's not quite as effective as the other MAOIs. And so, you know, if you're in one of these other countries and you love this drug, comment down below. Tell me, we can't get it. And, I'm not sure if we need it or not. If you think it's a great med, I would like to hear about that. So that's actually the only antidepressant that's in the A category. But there are a couple other MAOa inhibitors, linezolid, which is an antibiotic, and methylene blue, which is a treatment for methylmoglobinemia. And so I think whenever if you guys are ever looking at like drug interactions and you're looking at something like serotonin syndrome, or, don't mix this medication with an antidepressant. Yeah, this is an important one to know. Linezolid is an antibiotic. It's given in severe cases of infection. And if you're going to give somebody linezolid, make sure they're not taking uh, a medication that increases the monoamines. So those would be all your SSRIs, SNRIs, all those type of medications, the TCAs, for you medical doctor, as a psychiatrist, I'm never going to give someone linezolid. But if you are and you've got someone in the hospital, make sure you get them off of those other medications. And this is why, because linezolid's not just an antibiotic, it's an MAO inhibitor. Okay. And so we can't mix MAO inhibitors with those other antidepressants. And it is one. And then methylene blue, methylmoglobinemia is a pretty rare condition. I've never seen methylene blue used. I see it on these lists of interactions. But if someone's going to be using methylene blue, they also can't be taking those medications. And that's why, because not only does it treat a medical disorder, it's also an MAOI. Okay, and then those are the ones that affect type A. And then what are the ones that affect type B? So selegiline, which is known as Deprenyl, came out in 1989. And then the patch form, MSAM, came out in 2006. Interesting fact on that, MSAM actually stands for Emily and Samuel, the children of the person who came out with this medication, named it after his kids. That's where MSAM comes from. And so this is selegiline. It's used for Parkinson's, probably not that much anymore. I don't treat Parkinson's, so I don't see it a whole lot. It used to be a more common medication used for Parkinson's. It's actually selective for B up to 6 milligrams. And so MSAM, if you go over the 6 milligrams, it's not selective. It also affects A. And we're going to talk about why that's important, that it's selective for B versus A. And then rasagiline, also known as Azilect, came out in 2006, used for Parkinson's. It's selective up to 1 milligram. And then also kavalactones, which are found in kava kava, which is a medicinal root used in Micronesia, Polynesia, Melanesia, the islands of the Pacific. It's kind of like their drug, their peyote, their tobacco. I've actually used kava kava before. I may talk about it a little bit later. But kavalactones are the active ingredient in kava kava. It's a very bitter tasting root. If you're in Hawaii, Hawaii has this. It's not illegal. It's a somewhat mind-altering substance. People use it for anxiety. It's kind of it's a social thing where you have like a kava drinking ceremony, and they pass around this cup that has the kava in it. It's a kind of muddy brown liquid that you're not supposed to drink that kind of muddy bits, just the liquidy parts. But apparently these kavalactones also, they have a lot of effects. They affect GABA, they affect a lot of different things, but they also MAOB. So let's talk about the difference between A and B, because you're probably wondering, why do I even care if something's selective for A or B? Like, what's the difference? So as I said, these break down monoamines, and they actually, A breaks down different ones than B breaks down. A breaks down serotonin, norepinephrine, dopamine, melatonin, and tyramine, right? We all know about the tyramine reaction, and this is where this comes into play. So when we had those ones selected for B, like the MSAM up to 6 milligrams, it's not, you don't have to worry about the tyramine reaction for that because it's not affecting A at that dose. And so this is the hypertensive crisis, right? And I think people, they associate the tyramine and the hypertensive crisis, but like, how does that actually like happen? How do we go from tyramine to hypertensive crisis? So what actually happens is tyramine is converted to another compound called octapamine. And octapamine, I'm not 100% sure how to pronounce that. I've never heard it said. But what this is, it's actually a false transmitter, which causes a massive release of norepinephrine, which could result in a hypertensive crisis. So it's the tyramine turning into the octapamine. And what happens is it releases massive amounts of norepinephrine. That's how that happens. And that's how we get the hypertensive crisis, because norepinephrine interacts with your adrenergic receptors, your alpha and your beta, and that can increase your blood pressure to an extremely high level. And we're going to go into a little more detail about the tyramine stuff in a second. I just want to mention what MAOi breaks down. So it breaks down phenethylamine, and phenethylamine is actually a TAR1 agonist and a VMAT2 inhibitor. And so I think that those are two things that a lot of people are looking at, the VMAT2s and the TAR1s and that whole thing. And essentially its effects on TAR1 and VMAT2 leads to an increase in serotonin, norepinephrine, and dopamine. I don't know how much of the MAO's mechanism of its effect is through the phenethylamine increasing those same things that it's already increasing through the MAOa, but that's what that does. And then there's some other ones, benzylamine. I'm not sure that actually has any effects in the body. Dopamine's also broken down by type B, and then tyramine to a much lesser extent is B, but not to an extent that we worry about. All right, so what are the adverse effects of these? So I want to go over the adverse effects of the MAOIs as a class, and then we'll go through each med individually and talk about what the differences are in between each one. So kind of generally as a class, and you're going to notice that these side effects are very similar to the side effects of serotonin reuptake inhibitors and norepinephrine reuptake inhibitors, because, surprise, this is increasing serotonin and norepinephrine as well, right? And so you're going to have very similar side effects. That makes sense. And you're increasing serotonin, norepinephrine, and dopamine. And so you've got one drug that's increasing all of the monoamines that we use to improve mood, with other medications which typically only affect one or two of those. And so that's one thing that could be great about this medication, is it's one drug that does all of this. And so some of the adverse effects: sedation, insomnia. So as we know, same thing with this serotonin, it can either make it easier for you to sleep or less easy. Headaches, disorientation. You can have the manic switch, if someone has bipolar disorder, even if they don't, you could have like a little bit hypomania happening there from the increase in serotonin. And then this next one's actually an effect that's unique to the MAOIs, and because it's not an effect of serotonin, norepinephrine, or dopamine, and that's orthostatic hypotension. And this is one that you really want to know. And like, if you're studying for an exam and you want to know like a big difference, you've got the hypertensive crisis, and it's kind of interesting, right? Because these are opposite effects. Hypertensive crisis, really, really high blood pressure. And then you also get orthostatic hypotension, which is, drop in blood pressure upon standing or sitting up. And this is actually much more common. You only get the hypertensive crisis if you eat the foods rich in tyramine. But you're much more likely to actually get the opposite effect. And so you must be wondering, like, how does this drug cause both like severe hypotension and severe hypertension? Well, it's through different means. The hypertension, remember, is caused by it blocking the breakdown of tyramine. And if you have a lot of tyramine in your diet, then a lot of that tyramine gets turned into the octopamine, and then um, that causes the massive release of norepinephrine. But the MAOIs themselves actually have an effect to prevent the release of norepinephrine. So not through the tyramine pathway, but just through their own effect. And we're not exactly sure if this is, how this works, but they can actually prevent the release of norepinephrine from sympathetic nerve endings in a similar way to beryllium. And beryllium is a really, really old medication that used to be used for high blood pressure. It was taken off the market and then it came back, but I've never even heard of it until I did the research on the MAOIs. I've never seen it. I've never heard of it, but the MAOIs actually have a similar mechanism of causing hypotension as this old hypertensive medication. So that's hopefully that helps you understand the difference between why these medications can cause really, really low blood pressure, because they have this effect of preventing the release of norepinephrine at sympathetic nerve endings, and also can have the really, really high through the tyramine pathway. All right. In addition to orthostatic hypotension, other cardiovascular effects, decreased heart rate, and then of course the hypertensive crises, right? And the orthostatic hypotension is actually worse with phenelzine than the other MAOIs. So that's another important thing to know, that phenelzine is the biggest culprit. There's also some endocrine effects, anorgasmia, sexual impotence. Those are effects of serotonin, SIADH. That's the syndrome of inappropriate ADH hormone release. That's something that happens in the kidneys, and so that can actually affect your fluid levels that your kidneys are controlling, and that's something that SSRIs, so that's the serotonin effect that's happening there. And then looking at the GI system, so dry mouth, constipation, urinary hesitancy, weight gain, diarrhea, dyspepsia. So the diarrhea, dyspepsia, that's a serotonin effect. We have a lot of serotonin in our gut. We'll go over that a little bit more later when we get to SSRIs, but that's an increased serotonin effect. And then the other ones are anticholinergic effects. So these medications also have some anticholinergic properties, and some more than others. I think phenelzine actually has more of that as well. But there are some good points about phenelzine, so we'll go into those as well. And then selegiline, specific to the patch, you can get an application site reaction from the glue, and you can treat that with a diphenhydramine or Benadryl or lidocaine gel, so like a topical antihistamine. And you can use some alcohol swabs or soap and water to get the glue off. So some people react to the glue that's in that patch. And so if that happens, of course, we don't want to use the medication, and we want to then get that glue off with some alcohol and soap and water. And then we could treat that with an antihistamine or a numbing gel to help with that. So, I've talked about the hypertensive crisis a lot. Let's go into more detail on that. So it's the tyramine, as I discussed, increasing, we're decreasing the breakdown of tyramine, which is a monoamine. And so there are foods that are rich in tyramine that we want to avoid. And if you're going to take one of these, I would encourage you to look this up and find the list, because there's a lot of stuff on the list. I've tried to make a little summary list here for you. But if you're concerned about a specific food that sounds like it may or may not be in one of these categories, I would suggest consulting your doctor, as I would with anything, or, consulting one of these lists. And so these are things that you definitely want to avoid. A lot of alcohol is on the do not list. So, but some alcohol's okay and some alcohol's not. So homemade beer, And certain kinds of beer, like, I mean, and the foods that I think about avoiding, and a lot of people, I've heard people say, the foods that you have to, a lot of people might be turned off of taking these medications because they don't want to have to change their diet. And then the selling point is, well, these foods aren't even that good anyway. You're not really missing anything. Well, I love these foods. The foods on the definitely avoid list are foods that I absolutely, they're some of my favorite foods. And they may not be everyone's favorite foods. There are a lot of age spoiled, you know, those fermented, strong tasting, almost rotten tasting, things. And that may sound disgusting to a lot of people, but to me, I love flavor. And these foods have so much, a lot of them smell, and so the foods that tend to be like more aged and fermented are the ones on the that are high in tyramine, and the ones that are safe are, less spoiled, less fermented, less aging, pasteurized, fresher. So a lot of cheeses are on the avoid list. But then, say like a cottage cheese or fresh mozzarella would be okay, right? Because it's not aged, it's made fresh and sold, and these are great cheeses too. But I love a good aged cheese. And so if you're taking one of these medications, and if it's if the only thing that works for you, then I would recommend changing your diet, because you certainly can't take these tyramine rich foods. So a lot of the beers and wines, so red wine is on the avoid list and white wine is on the okay list, but don't drink too much of it. Um, the domestic kind of tasteless beers, as I would say, are on the okay list, whereas like the stronger, more flavorful beers are on the avoid list. But at the same time, like a Czech beer, like a Pilsner, which I think, is a less flavored beer, that's my opinion. It's actually on the avoid list. And so it's difficult, right? So homemade beers, red wines, definitely avoid. Aged cheeses, sauerkraut, dry sausage, cured meats, fava beans, Italian green beans, smoked fish, liver, aged soy sauce, most soy products, unless it's like a fresh soybean, brewer's yeast. And so that's like Vegemite. If you're down under, if you're down under, thanks for listening. And I love Vegemite. I actually eat Vegemite, and I'm probably one of the only Americans that does. And so if you're in America, you're probably not caring about the Vegemite, but that's on the avoid list. Sourdough bread. So most bread's okay, but you've got a lot of the live fermentation going on. So sourdough bread out. And then most pickled and fermented foods, things like kimchi. I love pickles. I love kimchi. I love all those things. But those are all no-nos for the tyramine and the MAOIs. And so, kind of like medications, if you're going to stop the medication, you can't just start eating this food right away, right? So just like you have to wait 2 weeks, right? Because we have the irreversible nature. So we need to get all of that inhibited MAO out of your system 2 weeks, and then you could eat these foods again or start. And then those are the big ones. There's some other foods that are on the maybe problematic list. um, Overly ripe avocados and bananas are on there. Another food that I like. And I don't know what would classify as an overly ripe avocado versus a non overly ripe avocado. Um, I I only like the really soft avocado. I don't want to eat a hard avocado. So I'm thinking that like the kind of avocado you eat would be overly ripe. I mean, because if it was like black, you wouldn't want to eat it to begin with because it's bitter and disgusting. Um, and then bananas. I only put overly ripe bananas in like a banana bread or in like a smoothie. I wouldn't eat an overly ripe banana. So bananas, if they're not overly ripe, typically okay. If they are overly ripe, might be problematic. Not a huge no. I'd probably stay away. Dried fruits, yogurt, most alcohol, caffeine. Sour cream's on the maybe problematic list. I've seen it on the safe list. Cream cheese is on the maybe problematic. I think cream cheese is probably okay. But if you eat a ton of it, that might be a problem. Same with the sour cream. If you have a little dollop of sour cream, I wouldn't think that would be much of an issue. But if you have a ton of it, that would be not great. And you probably don't want to play around with it. So you probably just, to be safe, would avoid. Chocolate might be problematic. Peanuts, and then foods that are mostly that are probably safe. Like I said, unaged, unfermented, unspoiled, unpasteurized, or pasteurized, and the fresher versions. Like, so not your aged and your cured. It's like your fresh meats, not your aged meats, right? So your fresher products of the above. And then there are alcohols, certain domestic bottled canned beers, white wines, and spirits at one standard drink um, is okay. But I mean, I would probably not recommend drinking too much anyway, just in general. And so if you combine these with MAOIs, leads to a hypertensive crisis, which could cause a stroke, right? So we don't want that to happen. And the treatment that is typically done is IV phentolamine or chlorpromazine, which is actually Thorazine, which is an antipsychotic that we will talk about. And the reason why Thorazine or chlorpromazine could be used is its alpha blocking um, potential. It can calm you down because of its antipsychotic properties, and so I think that may be why it's on here. But then its alpha blocking properties could be used for the hypertensive crisis. But like, most of us are not going to be treating this. If you're an internal medicine hospitalist, you might see this. These medications are not used very often, but we really need to be concerned when they are. So moving on. So those are some food interactions. What are some drug interactions? So serotonin syndrome, if you combine them with other serotonergic medications, and I'm going to go into serotonin syndrome in deep detail when we get to the SSRIs, because if you listen to the SSRI lecture, I want you to hear about serotonin syndrome, and I think a lot of people might skip this one. So I'm just going to mention it. And MAOIs are actually one of the worst medications to combine with serotonin medications. They're actually one of the most likely to cause a serotonin syndrome. And I think I'd have to look this up again, but there was the court case that led to the decrease in hours for medical interns and residents, capping a limit on how many hours they could work in a row as trainees, was because one of them gave somebody serotonin syndrome and they died. And when you actually look at the case, it was not because they hadn't slept really, and it was a mistake they probably would have made anyway, and it was a very difficult thing to catch. But it's an interesting historical piece of information, and it was actually Demerol, the analgesic that was given in the ER, and the patient, I believe, was on an MAOI as an antidepressant. This is like 1989 or something like that. I'll look it up, so when we get to the SSRIs, I will have that story for you, because it's an interesting story. But yeah, so MAOIs, you really have to be careful with these. When I give someone an SSRI, I might give them a trazodone or something, another serotonin medication. But I mean, some of these medications that are serotonin are actually not ones that we should worry about. Trazodone is one of them, but they'll be on lists anyway. And so I'll often combine serotonin, different medications that have the same pathway, and you'll see why, because we're treating different things with different meds. But this is something you really should not do with an MAOI. Kind of like the tyramine reaction, MAOIs are the one med that I would not combine with any kind of serotonergic medication at all, pretty much ever. The other ones, I might pair them together, but I would not pair them with an MAOi. So it's very important to know about the serotonin syndrome, and some of the big ones, and a lot of the ones that we may not think about. So, what are some medications that have serotonergic activity that are not traditionally thought of as serotonergic medications? So, meperidine, Demerol, epinephrine, right? So, if you're, and epinephrine is often given with surgery, and so we often have to hold these medications for 2 weeks before somebody can have a surgery because they won't be able to have epinephrine. And that's another thing to be concerned about, because if you have allergies and you might have to take epinephrine shots, then you really should not be taking an MAOi, because there is some serotonergic activity with epinephrine. Of course, don't combine it with another MAOi, and I don't think anyone would do that, but they might use linezolid, the antibiotic, so which is another MAOi. You probably wouldn't use two antidepressant MAOIs, but you might use another type of MAOI. Ketamine, dextromethorphan. Okay, I mean that's cough medicine. People can buy that off the shelf, and so if there's ever an interaction that someone's going to have with a medication that they could acquire not from a doctor, I'm going to tell them. So if before I give someone an MAOI, I would say, don't take cough medicine. If you get a cough, call me. I'll tell you what's safe to take. Um, Dextromethorphan has SRI or SNRI, I forget which one, but it definitely has SRI activity. And so it also doesn't work that well, by the way. And I've got a whole lecture on dextromethorphan abuse and everything. And that's a really good one. We'll go over that episode in the future. But no dextromethorphan with the MAOIs, none of the serotonergic medications, your SSRIs, SNRIs, TCAs. But with the TCAs, we're mostly worried about the ones that have the serotonin activity. Not all TCAs have a lot of serotonin activity, and we'll go into that when we get to TCAs. But the ones with a lot of serotonin activity are amitriptyline, imipramine, and clomipramine. Those are the big ones to remember. The other ones, not so much. Another one, brompheniramine and chlorpheniramine. Those are antihistamines that are also found over the counter. So if you're going to take cough and cold medication, you got to worry about the chlorpheniramine, brompheniramine, and the dextromethorphan. So this is why, folks are afraid of MAOIs and they don't want to give them to patients. You've got to give them, you've got to give this person the long tyramine talk, and then you've got to give them the long serotonin syndrome talk. All right. Like, am I going to combine chlorpheniramine with an SSRI? Sure. Why not? Dextromethorphan with this SSRI? Sure. No problem. With an MAOI? No. SAMe, we're going to talk about SAMe at the end of our depression. That's another medication used for depression that's only available over the counter. L-tryptophan, that's a nutraceutical that people might buy at the store. St. John's wort, something people could buy on their own. And then a lot of illicit drugs, cocaine, MMDA, ecstasy, LSD. So we got to make sure you're not abusing illicit substances if you're taking an MAOI. And then ziprasidone and lumateperone are antipsychotics that have serotonergic activity that we don't want to combine with MAOI. And like I said, that was a lot of detail, but I'm going to go to even more detail because there's a lot more to do with serotonin syndrome than just that. And then a drug interaction specifically for MSAM is carbamazepine. Carbamazepine can increase the levels of the drug and the metabolites. So be careful with that. Carbamazepine not used a whole lot anymore, but it does have an interaction warning with MSAM or selegiline, right? We MSAM is the only, the patch is the formulation that's approved for depression. The pill form is not approved for depression. It's only approved for Parkinson's. So we probably wouldn't be giving the pill form. And also we get the advantage of the 6 milligram dose, not having the tyramine reaction for the MSAM. Also for MSAM, so it has all the same interactions that the other MAOIs, but it also interacts with cyclobenzaprine, Flexeril, tramadol, methadone, propoxyphene, which I don't even know what that is and I've never seen it used, and then oxcarbazepine. So the MSAM has a few extra interactions to think about: cyclobenzaprine, tramadol, methadone, propoxyphene, and oxcarbazepine. And cyclobenzaprine is a super common given medication. Um, it's a muscle relaxant. And then tramadol, also pretty common analgesic medication. And then the other one's less so, but they are available. And then, so those are some of the interactions. What are the absolute contraindications to giving MAOi that I haven't already talked about? So phemochromocytoma, really rare disorder that none of you will probably ever see, that causes hypertensive crisis. Obviously, don't give it with MAOi. It's a tumor of your adrenal glands, super rare. I've even heard that endocrinologists have never seen it. It's just not very common. Hepatic or renal dysfunction, do not, if they have any hepatic or renal dysfunction, no MAOi. If they have a cerebrovascular defect, so we're worried about this hypertensive crisis. So a lot of this has to do with that: the pheochromocytoma, the cerebrovascular defect, and cardiovascular disease. We don't want to give MAOIs to those folks. So anyone who's like sensitive to blood pressure, we don't want to do it. I mean, because even the slightest hypertensive crisis that someone might have could lead to a stroke. We want to give this medication to more medically healthy individuals. So patients undergoing elective surgery, remember, we have to hold it for 2 weeks. And I guess if you're going to have emergency surgery, surgeon should know that you're not supposed to get epinephrine. And then don't use it within 5.5 half-lives of a serotonin reuptake inhibitor, which is around 1 to 2 weeks. Okay. But some of the SRIs have longer half-lives. So vortioxetine has a longer half-life. So instead of 2-week wait, we're waiting 3 weeks. And interestingly, there's a warning on vortioxetine for 32 days if you have a BMI over or equal to 35. And so I guess for heavier individuals, vortioxetine has an even longer half-life. And so we have to wait even longer. So 3 weeks for standard, and then looks like about 4.5 weeks for over 35 BMI. 5-week wait after stopping fluoxetine Prozac. So it has Prozac has a very long half-life of about a week. And so 5.5 half-lives is going to take us to about 5 weeks. We have to wait 5 weeks. And the reason we're doing this is because we're trying to avoid serotonin syndrome, right? And so you have to wait 1 to 2 weeks after stopping your, say you're probably on a serotonin medication before we use an MAOI, right? And so, and say it didn't work, and now we want to up the ante and go to the MAOI, but we have to wait the 1 to 2 weeks. We have to wait for that medication to completely get out of the system so we don't get serotonin syndrome. So 1 to 2 weeks for most drugs, 3 for vortioxetine, 4.5 for BMI over 35, 5 weeks for Prozac. And so you're thinking, gosh, that sucks. So that means this person has like no antidepressant at all for like 2 to 5 weeks. Well, what do we do? We can try and bridge them, right? So if you are switching them from a serotonergic medication, if we're going from Wellbutrin, bupropion, then we don't have this problem. But if we're going from a serotonergic medication, we need to bridge with a stimulant. So we could use like an Adderall or something like that, a benzodiazepine, a trazodone, because remember, trazodone, it blocks serotonin. It has very weak reuptake inhibition, very weak. It's mostly a serotonin blocking medication. And then mirtazapine, which also is mostly a serotonin blocking medication. Okay, so you could bridge them with those, or you could straight switch them to one of those. I mean, I wouldn't switch them to a benzo or a stimulant. Maybe mirtazapine would be an option to switch to. But if you wanted to get them onto like, we're going from an SSRI over to MAOI. So in the meantime, give them one of those medications. An atypical antipsychotic other than ziprasidone or lumateperone. So try to find something that's not serotonergic that you can give them in the meantime until we can then start the MAOi. And then, as I mentioned, if we're going the other way, right? So if we're going from SSRI to MAOi, we have to wait to get it out of our system for the effects of not wanting them to get serotonin syndrome, right? We need that SSRI cleared so that we're not getting that serotonergic effect. But if we're going the opposite direction, we still have to wait. If we're going from an MAOi to one of those medications, it's a straight 2-week wait, right? Because we have to wait till that inhibited MAO metabolizes out of their system and they create new MAO that's actually functional. So when we're going to an MAOi, we have to wait for the other medication to metabolize out so that we don't get serotonin syndrome. But if we're going from an MAOi, we have to wait for that MAO to be recreated. And that takes 2 weeks before we can start the SSRI. So a little bit different and a different reason for why you might be going one direction or the other. And so just a lot of stuff to know about these meds. So let's have a summary. Let's put it all together. This is what I like to do with all my meds, and I'm so happy we got to this point. This is the first point. We're talking about real meds, and we're going through like kind of my comparison. So MAOIs, what's good about it? What's bad about it? I feel like that is sum it all up. Good points. Inexpensive, right? These are old drugs. They cost almost nothing. They might help with treatment-resistant depression. So whereas the other depression antidepressants they took weren't working, this one might. Could help in an atypical depression. And that's a depression. We'll talk about that. We're going to talk about subtypes of depression and how to treat those specifically later. But atypical, that's where you're eating more and sleeping more. Kind of not the typical presentation for depression. These might be helpful. A social anxiety disorder is something specifically that these might respond to. A panic disorder, anxious distress. So specifically phenelzine, and we'll talk about why, could be even more beneficial for anxiety than the other serotonergic medications. And then the fact that we have the patch option. Some people just might like the idea of having a patch rather than taking a pill. And so this is the only antidepressant that comes in a patch form. And so that might be preferable for some reason. So those are some good points. And then what are our disadvantages? So we talked extensively about these. The drug-food interactions, the drug-drug interactions, the side effects, all the litany of contraindications. The fact that this is like a last line, because of all these other things that we have to go through and deal with. The difficulty in switching. We talked about switching to it or from it is quite difficult. And then the selegiline patch, and we'll go into this a little bit more, the dietary advantage only being at the 6 milligrams, and that usually isn't even that effective. And so even though, we're only doing the MAOB, and so we don't have to worry about the tyramine stuff, that's only at the lowest dose. At the higher doses, we still do. So is that even really an advantage? So those are my list of advantages and disadvantages. And then the next slide, I like to do this for all meds because I think this is great for those of you that are taking tests and, or those that are dealing with like complicated insurance problems, and you need to know, what is this approved for and what is it off label for, right? And for the MAOIs, it's very simple. They are each only approved for major depressive disorder. Isocarboxazid, phenelzine, tranylcypromine, and selegiline only approved for major depressive disorder. And selegiline only in the patch form, I believe. And then selegiline and rasagiline are approved for Parkinson's disease. So selegiline for both, rasagiline's only Parkinson's, and all the other ones we've talked about are only major depressive disorder. They have no other FDA approved indications. And remember, these were approved like 60 years ago. And so if you look what they were approved for, it was actually something like depression or something different like that. But it's been kind of categorized as major depressive disorder in today's terms. So first one, now we're going to go through each med and kind of the pluses and minuses and the differences. So the first one to come out, isocarboxazid, Marplan, 1959. It's thought of as less activating than some of the other MAOIs. So if you're having some like overactivation, which means like maybe more energizing, more makes you want to move and get up, and if you're looking for something that's going to cause less of that effect, then this might be your choice. It's less studied than the other ones, and it's less used. So isocarboxazid is between the three of isocarboxazid, phenelzine, and tranylcypromine, it is the least kind of thought about. And so there's just like less information on it. You have to monitor liver function tests. That's recommended by the manufacturer. And that's the case with, I think, all of them. And then the dosing is kind of unusual, but it's the same unusual dosing for all of them. So with this one, you start with 10 milligram test dose on the first day. If they tolerate that, you go to 10 milligrams 3 times a day for the first week. And then you can go up by 10 milligrams weekly until you're limited by side effects or reach a max dose of 50 milligrams. And then I think you can eventually get that to just once daily dosing. Because remember, its effects are on the MAO, and that effect lasts 2 weeks. And so I think the having to dose it 3 times a day, that's just during the titration time. I don't even know if that's necessarily that critical, but that's the drug manufacturer's recommendation. And now next one, phenelzine, Nardil, 1961. It's the most used. And remember how I mentioned it has those anxiety effects? It actually, it's a GABA transaminase inhibitor. So it actually increases GABA in the brain. I don't know any other medication that does that. I know that there are medications that interact with the GABA receptor, benzodiazepines, and have similar effects as GABA, but this one actually increases GABA. And so that can help with panic, anxious distress. And some studies have shown that it's twice as effective for social anxiety as SSRIs, and it also can be somewhat sedating. And so I think this is something people don't think about. They think, oh, the MAOIs, they're just kind of similar to other medications. Why would I ever use this? Well, this specifically increases GABA, and that's a fact that no other antidepressant can claim. They can help with anxiety, but not through increasing GABA, and that's what this does. And so that's a unique potential benefit of phenelzine, and a reason why you should add it to your armamentarium and consider using it. So I have a note here that it can be used with amoxapine if they're started at the same time. Amoxapine is an antidepressant, tetracyclic antidepressant we're going to talk about in the next lecture. It's actually an antipsychotic, but it's not approved to be an antipsychotic, but it blocks dopamine receptors. It's pretty weak on the serotonin reuptake pump, and it's mostly a dopamine blocker. And so I think, I've read things that said don't mix phenelzine with amoxapine because it could cause serotonin syndrome. But I think this idea of starting them at the same time and low and slow is a potential option. And I guess the reason why this is mentioned is because we often use 2 antidepressants at the same time. But when we're talking about MAOIs, pretty much every antidepressant interacts with them. And this is one that at a lower dose, and if started at the same time, and you've got a really tough case, would be something that you could consider. But do recognize that serotonin syndrome is still a potential there, but it's at higher doses. Phenelzine is actually the most anticholinergic and most sedating. And so you look out for those anticholinergic effects. It's got the most weight gain, the most hypotension, the most sexual dysfunction. It can cause B6 deficiency. And so a lot of negatives for phenelzine, but it's got that GABA and that positive benefit for anxiety. So it might be worth a try if you're really having trouble uh, with the patient in that symptom. Also monitoring LFTs with this medication, liver function, and dosing is kind of similar to isocarboxacid, but with this one, we give a test dose of 15 milligrams the first day. Then we increase by 15 TID 3 times a day over the first week, and then add 15 until we're limited by side effects or reach a max dose of 90. So it's the same pattern, but we're dealing with different numbers, but the same pattern. And then we have tranylcypromine parnate 1961. It might work a little quicker. It is the most activating. So there's more insomnia with this one. And you could treat that insomnia with trazodone, because remember, trazodone does not increase serotonin. And so that's a safe medication to combine. It has some amphetamine properties that are dopaminergic at high doses. And so if someone does a drug test, they'll come up positive for amphetamines with this medication. And so they should not get in trouble for that because they weren't taking amphetamines. And so that's important to know. It's activating, and it might help with melancholic or apathetic depression. It's better tolerated than phenelzine and equally effective. So I think if I had more of a depressed patient, I'd probably go with the tranylcypromine. And if I had more of an anxious patient, I would go for the phenelzine. And then there are some reports that it could be used in bipolar depression. I generally do not like giving antidepressants at all to bipolar patients. And we'll go into that in a lot more detail in the bipolar lecture, but just a note that there are some positive reports for this one. And then once again, the dosing is actually almost exactly the same as it is for isocarboxacid, starting with the 10, but instead of a max of 50, the max is 40 to 60. All right, and then the last MAOi we're going to talk about is selegiline patch, brand name MSAM. So this is a matrix type transdermal system with 3 layers. There's a backing layer, an adhesive/drug layer, and then a release liner. And so that's how the patch is engineered. It's a 1 milligram per centimeter squared, delivers 0.3 milligrams of selegiline per centimeter squared over 24 hours. For those of you that are interested in that kind of technical stuff, this is our only patch. We have a patch for we have 2 patches for ADHD, but this is our only antidepressant patch. There's no studies for treatment resistance for the patch. Only studies are for the oral. It's available in a 20 milligram, a 30, and a 40, and each patch is actually larger. So 20 at 20 centimeters squared, 30 milligrams on a 30 centimeters squared, and 40 milligrams on a 40 centimeters squared. And it delivers an average of, so that's how much drug is in there, but the 20 delivers 6, is a 6 milligram dose, the 30 is a 9 milligram dose, and the 40 is a 12 milligram dose. I know that doesn't make much sense. There's 20 milligrams in the patch, but if you wear it for 24 hours, you'll get 6 milligrams from the patch. Okay, so that's how much is actually released. So when you look at the package, it says 20 milligrams, and then in parentheses, it says 6 milligrams per 24 hours. And so, I mean, I would assume if you wore it longer that it would release more, but it would probably release it slower and slower. And so you change the patch every 24 hours. And so the way we have to know how to use this. So if you're looking at the slide, there's a little diagram that shows you like where you can put it. So you want to apply it to dry, intact skin on the upper torso. And these are all the places you can put it: below the neck and above the waist. So upper thigh, so you can put it on the upper torso, in between the neck and above the waist. And then you can put it on the upper thigh or on the outer surface of the upper arm. So not in between the waist and the upper thigh. And so if you see on the diagram, it's got it on the chest, the deltoid, the upper thigh, the lower back, and then the upper back scapular region are places. And you may want to move it each day. I would not put the patch on the same site, right? So change the position of the patch every day and kind of cycle that through so that you don't have that drug going into the same place. It'd be more likely to get a bad reaction that way. Don't touch the sticky side because the medication might come off and then it would not get into your body when you put it on. And then this is the case with like all patches. Don't apply external heat source because that can actually increase the drug absorption. And external heat source, that could be don't wear it into a sauna, don't put a heating pad on top of it, don't be in prolonged sunlight for a long, in sunlight exposure for a long time. So don't have external heat on the patch. It increases the absorption, and then you're going to get too much, right? Because remember, there's 20 milligrams in that 6 milligram patch, and you only want to get the 6 milligrams. There's no dose adjustments for hepatic or renal dysfunction, so that's great because remember the other medications were actually contraindicated for hepatic or renal dysfunction, but this one, that's a good point. It's not. The dietary modifications, I've mentioned this 1,000 times. You still have to follow the tyramine dietary for 9 and 12 milligram doses. And if you go down to the 6 milligram dose, you have to follow it for 2 weeks because you have to wait for that 9 to kind of get out of your system. And if you stop it, you still have to wait the 2 weeks if you were on the 9 or the 12 dose. The unfortunate thing is that the 6 milligram dose is not that much more effective than your run-of-the-mill antidepressant. So that's unfortunate. So the one advantage we get where we don't have to worry about the tyramine reaction and the hypertensive crisis, it's at a dose that is probably no more effective than an SSRI. But, there may be patients where that's not the case. And so I wouldn't just, nothing in psychiatry is 100%. Nothing, it's a tends to, or probably not. There could be one patient out of 100 that has a completely amazing reaction that never happens to anyone else. That happens. Or it could have a side effect that you've never seen before. And you might discount the patient like, that's not in the list of side effects. One patient can have a side effect that nobody else has. That happens. And then the food reaction, we don't have to worry about at the 6 milligram dose, but the medication reactions with the serotonin syndrome, we still worry about that on the 6 milligram dose. The medication restrictions are still to be followed on all doses of the selegiline patch. It's activating, and this one will also cause you to be positive for amphetamines in a urine drug screen. So, wow, 1 hour, I did it exactly. We got through all the MAOIs. We talked about all the different types, all the ones that are out there, when we would think about using it. And I'm going to mention these later when I talk about the subtypes of depression. We're going to talk about, using MAOIs in those subtypes, and we're going to talk about them in the treatment algorithm, like where would they fit, right? Probably third, fourth, or fifth, no earlier than your third choice, and probably like no later than your fifth choice. And so we'll talk about that too. Whenever we kind of bring it all together and we say, which ones should we use when? And so thank you so much for tuning in. I hope you learned a lot about MAOIs. I hope you feel like you could prescribe these now, whereas maybe before you thought, hey, I'm not using those MAOIs. Like they are, like, out of every medication that psychiatrists can prescribe, they are probably potentially the most dangerous. That doesn't mean don't give them. That's why they're coming to see you. I'll get on my soapbox a little bit for a second here. Whenever I hear people say, I don't want to use Lamictal because of the Stevens-Johnson syndrome risk. I don't want to use, clozapine because it could cause agranulocytosis. I don't want to use lithium because, the therapeutic window, and I don't want to use MAOIs because of the drug-drug and drug-food interactions. No, no, no. I mean, if you're a primary care out there and you're listening, and I hope you are, and thank you for listening if you are, you should probably not be using these medications and giving them to patients. Um, I think it's good for you to know about them because you're going to have patients come and they might be taking them, and you need to know what's up with these medications. You might want to call your psychiatrist friend to ask them if you have a question. Um, but if you're a psychiatrist, you should be using all of these medications, all of them. Like it, that's you're the specialist. I see, like I said, I see this all the time, and like folks, they don't want to prescribe these medications because of the risk, and it's like, no, no, you're the person that would prescribe them. Primary care can give people an SSRI. They can give people some of these less dangerous, less complicated medications. But you, as the psychiatrist, you're the one. Who else? If not you, then who? I think there's folks out there that might say, "Oh, I want to send them to like a specialist that like treats treatment resistant depression and someone who has experience with MAOIs." And it's like, you should have experience with MAOIs. These patients are being sent to you because they've likely already failed a trial of an SSRI. They probably failed 2 or 3 trials. They're being sent to you because that stuff didn't work. Now, it may not have been prescribed in the ideal way. There may have been an interaction, or the dosing may not have been appropriate. And so you definitely are going to still be using those medications. But you should also have this MAOI in your back pocket, because if they've had 2, 3 good trials of other meds, and then they're being sent to you by their primary care doctor because they're like, hey, I don't know what to do, this person's just so depressed, and like I've tried like all the stuff that I'm comfortable with, psychiatrist help me. And I think one thing I see a lot of is I see a lot of second generation antipsychotics, which I'm not a huge fan of, and we'll talk about them too, because several of them are FDA approved for depression. 4 of them are. I see a lot of that. I see a lot of people that they get an antipsychotic added on. It's very common, and not the MAOI, not the tricyclic, not some of these older treatments, which we should be considering. And honestly, I would probably reach for an MAOI before I reached for an antipsychotic. Maybe this is blasphemous. And I'm not saying that there aren't cases where I wouldn't do the opposite. And I told you before, that I've only prescribed this one time. I gave MSAM to a patient once. But I also, and this may shock you, I almost never would give antipsychotics to depressed patients. Just didn't do it that often. I received a lot of patients that were on them, and I just saw a lot of side effects. I saw a lot of akathisia. I saw a lot of side effects, and I didn't see a lot of benefit. I mean, I saw a few, and of course, I have done it. And I've seen patients that I've given the antipsychotics to do well with that added on. I'm not saying that we shouldn't be doing that. I'm just saying that we shouldn't universally say, antipsychotic is, after they have like the antidepressants trials, I'm going right to the antipsychotic. Why not try the MAOI? I wish I had done it more. And I'm not currently practicing. I retired from the military about a year ago. Um, I've been doing a lot of things with family and getting my life straightened out, and like working on a lot of projects at home, and like the podcast and things like that. And I think in the future, I'll probably practice again. But right now, I'm not. And so I say in the future, I think I'm probably going to reach for these MLIs a lot more than I never thought about before. And I hope that you, after hearing this, will consider that as well. And maybe instead of just always reaching for the antipsychotic because it's easy, because patient's not going to have a chance of death from the antipsychotic, like their chance of dying from giving them an antipsychotic, that's, just looking at safety is not the only reason to give someone a medication. We should be looking for what's going to be the most effective, safest medication. And I think ignoring this class is doing a grave disservice to folks that might benefit from it. And I'll tell you that one patient that I did give this to, he did well with it. He did well with it. And I had him on the patch, and I had him at over a 6 milligram dose. And so we still had to worry about all the drug and drug food interaction. He was actually a patient he was one of my psychodynamic cases. And so I was doing psychodynamic therapy, and I was giving him the MSAM patch. I mean, he was a severe case. That's why I chose him for the therapy. And so I knew this patient very well. I saw him more. I had more appointments with him than probably any patient I've ever seen. Probably saw him 40 times. And so I got to follow quite closely and see what that medication was doing for him. And we kept it the whole time, and that was his med. And so, and that was at a time when I was, when I said when I was overseas, which was for the last, 6 of the last 7.5 years of my career, I couldn't have gotten any of these medications anyway. But I think I dismissed them too much. And so there's my soapbox. Don't just reach for the easiest, safest thing, because, every medication has adverse effects. Those antipsychotics cause a lot of weight gain, and that causes so many problems. I mean, we already talked about how being obese can make your mood worse, right? And so this medication may cause weight gain, but probably no more than a serotonergic, SSRI type of medication. And so I'm going to end it there. Next time, I'm going to go through all those receptors in the brain, and we're going to hit TCAs. And so thank you so much for joining me, and I hope you come back next time.